we looked at the arrival time and the time to first opioid pain medication. So the vast majority of children who come with sickle cell pain crises have tried pain medications at home. So they have failed those. So at that point, it makes the most sense to escalate to this being a more moderate to severe pain episode. So we looked at time to first and really dichotomized it as, did they get the first dose within 60 minutes? And because we didn't want people to just say, well, if I give one dose fast and then ignore them for the rest of their ED stay, or am not efficient in giving the second dose, we then looked at the combined, or the most important results of this are the combined first dose and combined second dose. And then because we wanted to look at the National Heart, Lung, and Blood Guidelines, which was 30 minutes, and the ASH guidelines, that was 60 minutes, we looked at, was the first dose given within 60 minutes, and then was the second given within 30, within 45, within 60, with the idea that if giving it within 60 is helpful, but 45 is more helpful and 30 is even more helpful, at least we can tell sites, look, aim for 30, but if you get to 45, there's still a benefit. Don't just ignore and say, oh, we're giving up because we can't get to 30. Or if 45 was good and 60 wasn't, then you really got to get to 45, although the ASH said 30 to 60. There seems to be a difference if you can get it faster than 60. So that's really what we wanted to show. A large percentage of people got 2 doses, which is why I think the analysis of the 2 doses is important. The first dose does matter. It is helpful to get the first dose within 60 minutes. There are more people discharged if you get the first dose in within 60 minutes. However, what we were able to show is that if the first dose is within 60 minutes and the second dose is within 30 minutes, the odds of being hospitalized are 0.62, which means 38% less odds of being hospitalized. Now, again, if it was 45 minutes, there was still a positive impact. If there was 60 minutes for the second dose, there was still a positive impact, although the impact seemed greater the faster the second dose was given. There's a lot of benefits in a lot of different spheres for why this would help. And I would say you talked about post the ED visit, but I think it might actually have an impact prior to the ED visit as well. And I will talk about that in a second. So let's assume that this means that they had better pain control and that's why they were able to go home. So obviously that means they're going home feeling better, right? Now, it's difficult to be in the hospital. It's disruptive to the child. It's disruptive to the parent of the child. So if the child is supposed to be at school the next day, they obviously are not going to be at school. So in addition to just feeling better, they might miss fewer days of school this way. If the parent needs to stay with them, if they are in the hospital, the parent might have less work days missed, less sick days missed. Now, we didn't study those things in this actual study, but you can imagine being home is more comfortable for the child, usually than being in a hospital setting. And now they are more likely to be able to return to their normal activities of daily living, right? Now, I think those are some of the kind of real world impacts of being able to go home as opposed to being admitted. I would also say that if you believe your pain is going to be taken seriously and you will be treated rapidly on arrival to the emergency department, it might actually encourage you to come more quickly to the emergency department. And I don't mean we want everyone running to the emergency department, but we have heard lots of stories, not as much in the pediatric world, but maybe a little bit more in the adult world, where people will do anything to avoid the emergency department, even if it's the right place to go for care, because they're worried about the perception of what's going to happen when they go, the worry about the quality of care that's going to be. So I think if we can get people to see, do what you need to do at home, try everything you can, talk to your primary care physician or your subspecialist to try to maximize your care. But the emergency department is just one more component of the care team to try to maximize your quality of life, improve your pain, as opposed to being this horrible place where nobody wants to go, right? And again, I'm not saying don't take maximal care at home. Do everything you can to stay at home. But I want the ED to be seen as a place you're going to receive high quality care and do everything they can to improve your pain to get you home so that you can continue that same quality of life that you want at home.